so I'm thinking that this is likely neuropathic foot pain because of her uncontrolled diabetes, right? So the diabetes is making neuropathic pain. And so she gets the amitriptyline, which also is not great for someone who is a more mature adult with multiple comorbidities. But guess what? She was a cash pay, and it was this or nothing. And so, despite the issues that she did have, the risk benefit analysis I made here was to put her on the amitriptyline to try and get some pain control for this foot, hoping that she would then allow for a more comprehensive management of her other medical conditions. So that's what she got. And it was largely because she was paying for it out of pocket, and it was all she would do. Also in the office, the metabolic panel and the A1C were drawn. She wasn't sure that she could pay for it, but she was going to apply for access to healthcare. And you know how the office setting is. I mean, we had a contract with the lab, so it was, of course, my desire to bill for this. But if she couldn't pay for it, it was really just pennies. I mean, pennies to order these two things. So I did them in the office. She was given clonidine also for that blood pressure, which is what we did then. In 2019, the National Heart, Lung, and Blood Institute published that lit review that really changed the way we approach the hypertensive urgency. But back in those days, the answer was to give a short-acting agent in the office and then have the patient sit and wait for that systolic pressure to come down to under 180. So she was given clonidine. She sat there for a while, and then she was asked to return to the office tomorrow. So meanwhile, here's the lab report. Let me see if I can blow this up for you. Here's the labs as they came back. So her glucose was 588. Her B1 and creatinine though. And no, this isn't an inappropriate diuretic. She just, for whatever reason, you know, her renal function was actually pretty good. It was actually fine. Yeah, her liver function was fine. Sodium was low, okay, but this is a totally different thing. Sodium was low, chloride was a little low. They tend to go hand in hand. CO2 a little on the low side. All very typical of the profound diuresis. Remember when we were talking about hyponatremia, and I said, next thing you consider is the osmolality, because we have isotonic, hypertonic, and hypotonic hyponatremia. I then pointed out that the most common cause of hypertonic hyponatremia was hyperglycemia. Like in this case, the reason I ordered the Osmo, and I ordered the Osmo at the same time as the other labs, not because I didn't know the cause of her hyponatremia. I knew she would be hyponatremic, and I knew why. I knew that the Osmo would be elevated. What I was looking for at this point was, does the osmolality rise to the level of hyperosmolar hyperglycemic non-ketotic coma, is what we called it then, or hyperglycemic, yeah, non-ketotic something.